Good afternoon, everyone. Welcome to the first Aspen Institute Global Health Roundtable series. My name is Peggy Clark. I'm the Executive Director of Global Health and Development here at the Aspen Institute, the newest policy program, and the Vice President of Policy Programs. We're so pleased to see a great turnout today, and we have a fantastic group of speakers who we will introduce in just a moment. I just want to tell you that this Global Health Roundtable series is beginning today. We plan to have at least 5 to 6 over the course of the year. We're hoping that our next speaker will be Dr. Paul Farmer of Partners in Health in Haiti to speak about the role of the health sector in reconstruction post the earthquake. But today we have a particularly wonderful panel of some of my favorite people actually working in the business, and we're very lucky to have Elliot Gerson as our moderator. Elliot Gerson is the Executive Vice President of Policy Programs and Public Programs and International Partnerships here at the Institute. He actually, some of you may not know this, but he has sort of one foot across the pond in the UK and one foot in the US. He's a graduate of Harvard, Oxford, and Yale. And he's particularly interested in issues of global health and in healthcare in this country. He's had a number of roles both in the public and private sector. He is sits at the American Secretary of the Rhodes Trust. So he has a deep interest in issues related to health in Africa in particular. He's had roles in government. He's been a Supreme Court judge, clerk, not judge, not yet. Anyway, he's been involved in a presidential campaign and in a number of other things. So I'll turn it over to Elliot to introduce our speakers today. Thank you so much, everyone. I do just want to point out when we finish our conversation, there will be books for sale and book signing in the back of the room. And also in the true Aspen tradition, we've left plenty of time for conversation. So please, we very much want you to engage as much as possible with this event today. Thank you.
Thank you, Peggy. Thank you, Peggy, very much. Thank you all very much for being here. We have 2 extraordinary speakers and 2 compelling, superficially distinct, but in fact closely related topics. We're going given the number of people here and all the things we want to talk about, I think we'll actually divide our conversation, including audience opportunity to participate, into 2 phases. We'll first talk about healthcare reform in the United States, context of the UK health system and the US health system, differences, also a little bit about what reform means in the United Kingdom. And then we will turn to a discussion of global health and particularly some of the things that can be learned mutually between developed countries and developing countries. And we'll probably spend about the same amount of time in each. Lord Crisp is an independent member of the House of Lords. He was chief executive, as I think most of you now know, of the National Health Service, which is the largest healthcare organization in the world, and we were just discussing this. It's also the 4th largest organization of any kind in the world, after, the Chinese Army, the Indian Railways, and Walmart. His new book, which we hope all of you will buy, Turning the World Upside Down, just came out in London last week. And the book is actually, I think, a further development of a report that he did for the Prime Minister in 2007 relating to the partnerships in health between the United Kingdom and other countries. He's also associated with the London School of Hygiene and Tropical Medicine. And very importantly, he has been a critical member of one of the Aspen programs headed by Mary Robinson called Realizing Rights, and particularly the Health Worker Migration Global Policy Advisory Council. And I'm sure in the latter half of our conversations today, we'll be talking about some of the problems about about migration, about medical personnel moving from developed countries, especially to developed countries. Actually, Senator Tom Daschle is also a member of that very same committee. Tom Daschle needs no introduction in this town, probably needs no introduction in almost any town. of course, the former Senate Majority Leader, an outspoken public figure on issues ranging from climate change to health care. Of course, a key advisor to the president on health care reform. Also the author of a wonderful book on healthcare reform, Critical: What We Can Do About the Healthcare Crisis, also for sale. And I understand, Tom, you have another book that's going to be coming out soon, this summer, which we will look forward to. We had thought about how we would divide this and what we would talk about first, but given the political earthquake in Massachusetts this week, we thought that we would start with a discussion of healthcare reform in the United States. And not to put you too much on the spot, Tom, but given what I'm sure is a question uppermost in most of our audience, even though many of the people here's interest is global health, what happens to healthcare reform now after the Massachusetts election? And some of you may not be aware, if you haven't seen the news this morning, Speaker Pelosi announced that there was absolutely no prospect, as I understand it, for the Senate bill to be passed in the House. So where are we?
Well, it's a very, very complex set of circumstances now, Elliot. If I had to guess, I would say that we're probably going to entertain the possibility of stripping down to some very bare essentials, an approach that might, again, allow the prospect of 60 or more votes. The real question, of course, as that happens, is to what extent will the Republicans be interested in participating in that effort. They've been emboldened, of course, with the election in Massachusetts not to participate, because what they have demonstrated in their lack of willingness to be involved is a political position that for them is very advantageous. It's, I would argue, a short-term advantage because in the longer term there are still demands for governance that I think are going to be so critical. I mean, the issues don't go away. We have an extraordinary access problem in this country affecting over 50 million people today. We have a problem that's perhaps even more exacerbated in the last couple of years, given the state of the economy. With every 1% of unemployment, you have another million people who are uninsured. We also have a cost problem. That cost problem now has brought us to a point where in the country we're $8,000 per capita in costs and taxes and premiums and out-of-pocket expenses, which is 40% more than the second most expensive country. And third, we have a quality problem. We have islands of excellence and a sea of mediocrity. We don't rank very well on outcomes, regardless of which source you want to go to. So those problems will only get worse. They're estimating if we do nothing, we will be spending $16,000 per capita within 25 years. We will reach 65 million uninsured within 15 years, and our precipitous decline in quality will continue. So it's going to be much, much harder to deal in a comprehensive way with all three of those issues. But if I had to guess, Elliot, I would say that they'll probably deal with insurance reform, attempting to address some of the concerns involving the rescissions, that is dropping people from insurance, the adverse selection, that is not allowing a person to buy insurance on the basis of health, the annual or lifetime limits that many insurance policies have today, those kinds of things. You're probably going to see some efforts at addressing Medicare in the payment and delivery reform categories, moving away from emphasizing value and putting greater emphasis on value. But most of that will all be demonstration and pilot projects. They won't have the authority to do much beyond that. So it's a significant loss for those of us who have advocated health reform, and it'll be some time before we can regroup and look with any optimism at passing something more comprehensive in the future. So just to summarize then, I would say that there are three options before the Congress right now. One is to do what I've just described, strip down the bill, try to pass something with or without Republicans. I would say the prospects of that happening today is the prospects are probably in the 60 to 70% range. The effort, that is, to do that. Whether it's successful is another story. The second option, which I'd put at about a 10% possibility, is to move off the policy process, which is the one we've been using. That is committees, floor vote, conference, and then the president's signature. Move away from that and go on to the budget process using what is commonly called reconciliation. That brings the threshold in the Senate from 60 votes down to 50 votes, and there is no prospect for a filibuster because you get a 40-hour time frame within which to debate any legislation on the budget process. That is extremely unpopular among many people just because it looks to be very partisan, and you have to sacrifice at least a third of the policy, the substantive policy provisions in the comprehensive bill. So I'd put that at a 10% prospect. The final one is just to drop everything like we did in '94 and just see what things we can do along the way incrementally. And I'd put that at about maybe 40 or 50% today.
Just to follow up on that, and a question about what, from your perspective as an advisor to the president, what's gone wrong? And I look at your title, critical, what we can do about the healthcare crisis. It almost appears that many American voters don't agree with your title, that they don't really believe that there's a crisis. Do you think that, in retrospect, that the messaging might have been a bit different?
Well, I think the closer you are to healthcare in this country, the more you understand the urgency of the problem, and whether it's cost, access, or quality. There's a 20-80 rule that many people refer to. 20% of Americans use 80% of the healthcare dollars. And that 20% clearly understand what a crisis we're facing. But to your question, your point, Elliot, that 80% really needed to hear, how is this relevant to me? How am I going to be affected? Now, to a certain extent, cost does address that, but if you get all of your health benefits tax-free, which we do in this country, you're immune somewhat from even that consideration, because unless you get sick, all you do every month is have your income deducted a little bit to pay for the health premium, not really even probably recognizing what that cost may be, and you become less and less concerned. So I think, if anything, and this is early morning quarterbacking because I think it'll take a little time, I think in part it was this perception that it's not as relevant to me as you all think it is, and I think the fear-mongers in this country won the day. They were able to say, that if at end of life the government's going to tell you you can't have a particular operation, that there are death panels out there, and that this is a government takeover, and all of the things that really cause the anxiety level to go up. The fear of the unknown is pretty powerful, and they used it very, very effectively. And I think there was also a perception, to a certain extent, that there were too many deals cut with special interests and other stakeholders, and I think that concerned a good number of people, in addition to the fact that this is an incredibly complicated issue to start with.
Yeah, but one of the messages that was not used as much, and this was a way we can perhaps bring in a discussion of the UK system, was whether the system is moral, or questions about equal access, or questions about just the sheer numbers of the uninsured. Maybe not the people who were voting, but many of the people who weren't voting who have no access to care. There seems to be a different premise in this country about health care than there is in the United Kingdom. And you write about this in your book as well, where you talk about cultural differences, and the UK system somehow based in notions of community and social solidarity, and the U.S. system apparently more sort of self-help and individualism. Do you see, from your perspective, or is it surprising from the British side to see the kinds of arguments that are made in the United States about health care compared to the ones that you see in the United Kingdom?
Well, I think it's very difficult actually for a foreigner to come and understand some of the process. I mean, there's one level we don't understand it on, which is, you say, is the cultural level. There's a film by T.R. Reid about health around the world, and there's a wonderful clip in it where he's in Switzerland and he's in front of the Prime Minister of Switzerland, and he says to him, how many people in your country go bankrupt because of healthcare costs? And the Swiss Prime Minister looks at him and says, none. It would be immoral. And it's just such a powerful sort of statement of actually where I suspect Europe is probably in that sort of realm of saying, actually, you know, health is for all of us in that sort of sense. So there is this social solidarity. In some ways, it's an insurance system, isn't it? I mean, something like the NHS is actually a state insurance system, which is there available for everyone without people paying in premiums. And that's where we're coming from, which is culturally very differently from where our understanding of your country about you know, looking after yourself and your family and so on, and not being dependent on others. And these two cultural things have led us to health systems that are very different. My theme is upside down. They're sort of the other way up from each other. You have a private system with a public safety net. We have a public system with the ability to opt out into the private sector. They're the other way around. And as a result of that, our risks are different. You have a risk of people not getting access, and you also have a risk of over-treatment because people will be selling you stuff. We have a risk the other way around, which is a risk maybe of under-treatment rather than over-treatment. And therefore, our reform processes have been in different directions. Our reform has been about how do you get some competition into provision, whilst keeping a single-payer system, and yours are much more about access and so on. So they're very different, so it is difficult to see. But our dialogue in Europe, I think, would be where you're coming from, would be much more about actually this is what our society is about, you know? And there's a big fraction of the British people who may not like the NHS on a day-to-day basis, but do think it's wonderful it's there, you know? There's that sort of bit in the psyche.
Let's stay on the topic, though, about healthcare reform in a British context, because there is movement for reform in Britain as well. I mean, some people might think, well, your system is established. And you say some very interesting things in your book about the resistance to reform in the United Kingdom that may be analogous here. You talk about sort of the legacy pushback, for example, and you talk about the inertia of the elites and the medical establishment. But to tell us a little bit about how reform plays out in the United Kingdom, and if there are any similarities with what Tom has described about the enormous difficulty in this country to change the system. There's a comparable difficulty in the United Kingdom to change its, but it's from a different premise.
Absolutely right. There is so much we have in common. We both practice medicine largely in the same ways. We both have, you know, common institutions and so on. So there is a great establishment that is invested in the processes and systems we have today. So how do you change that? I guess in the UK, one of the reform process we went through was slightly easier at the top, because actually, even though we don't have a president, we have a prime minister who has pretty presidential powers in terms of making more significant change and not needing to get through two houses. So there's a political difference, but then what we then had to try and do in making reform was to try and take that establishment with us, to steer that establishment, to try and make gains where we could. We didn't always take it as far as we wanted to, I have to say, but we did manage to make some significant changes in the UK. But recognising there is this great legacy kickback, this is great power block that you've got to work with to try and make change.
Tom, you were just talking about some of the challenges we have, and you also earlier quoted how the United States does compared to other countries. It seems that most Americans aren't really interested in lessons from other countries. I want to have a discussion about the strengths and weaknesses about the British system. But why is it so difficult for American politicians to get Americans to look at how the United States ranks in various indices of care, and even quality of care, not just access to care?
Like Americans, first of all, just can't accept the fact that we aren't the best. I mean, we live under a myth that we're the best. We have the best healthcare system in the world, which is contrary to fact. And but I think in part it's because they've had so limited an exposure to other systems. They really haven't been able to, and they confuse quality with technology. We have by far the best technology in the world, and they associate, well, if you've got access to an MRI, you must have the best system. You know, if we have a Mayo Clinic and we have world leaders coming to the Mayo Clinic, we must have the best system. Not everybody has access to the Mayo Clinic or to Intermountain or to Geisinger, and they overlook that fact, and they overlook the fact that technology in and of itself is not an index for quality. I think partly there's a confusion that comes from the perception that we're the best system in the world. There's also two other things. You know, there is a distrust of government in America that you don't find in Europe. And in large measure, the debate about health reform came down to a central question, Elliot, and that was, what is the proper role of government? You know, in Great Britain, about 3% of health is private, 97% is public. In the United States, it's around 45% public and 55% private. And you know, and so that it starts with that. Secondly, if you define healthcare system as having a central authority with universal access, we don't have a healthcare system in America. We have a healthcare marketplace. And that is a significant difference. And a lot of people pride themselves in not having a system and having this so-called free market in healthcare. And so that drives a big part of it. A huge amount of this is all about ideology in this country. It's not about health, it's about ideology. We also, I think Nigel might agree, you know, in all systems, because of the first two things, every country has what I view to be a healthcare pyramid, if you can imagine, where at the base of the pyramid you have good access to primary care and wellness. You work your way up the pyramid until at the very top you're the most sophisticated applications to health, technological applications like MRIs and heart transplants. Every country starts at the base of their pyramid and they work their way up. Oftentimes the money runs out before they get to the top. We start at the top of our pyramid and we work our way down. And so, you know, in emergency rooms we might have access to an MRI, but we don't get down to good, solid, efficient primary and wellness promotion in this country, and that is a huge difference as well. So all of these factors draw a huge contrast with other developing countries. But we're proud of that in large measure in this country, if you look at the polls, and that's what makes this change to systems that might otherwise put more rational thought into bringing about a system that provides better access, reduces costs, improves quality, into the kind of challenge that it has been these last couple of years.
Nigel, what is your response? I mean, you have a pyramid as well, but it's different.
We certainly put much more emphasis at the community end and at the primary end. You need both ends, and that is certainly true. And you will hear the critiques and the arguments in the press at the moment in the UK, and there aren't that many at the moment, not compared to what there have been like things about access to the very latest cancer drugs. And some of those are questions of access to cancer drugs, whether or not we actually really know whether they're effective or not. You know? But that's the sort of debate. So you're quite right, this is the debate much more at the top end of the pyramid. There's an assumption that you can get to an emergency room and you can get things sorted out. However, I do think that both of our pyramids at the moment are too much focused on the diseases of the last century, and that we're not paying enough attention to the chronic diseases and the continuing problems. You know, we've got systems, both of us, based too far, even though we're less so than you, based much more on hospitals and on a sort of professionalisation. Whereas actually the truth is, and I'm of a generation where with elderly parents and elderly parents-in-law, actually they don't get one thing wrong with them at a time. You know, there's always two or three things, and you've got to sort it out. And actually you need different ways of doing that. And our models are structured around a very industrial way of thinking about health. And that's something that we share, and we both have a problem. And some of our reform at the moment has been tinkering with that pyramid. I think actually we need to make some changes to the pyramid as well. But even so, I do think we're probably in the better position of having the stronger base than having the fantastically strong top on a pretty wobbly base.
One of the things, Nigel, it appears that you do, and I'd love to hear your comment on it, that the primary care providers appear to be the gatekeepers in your system as you move up the pyramid.
Yeah.
And, you know, but they're providers. In this country, I think the insurance companies largely are the gatekeepers. They're not the providers.
Yeah.
You know, there are people sitting in one of these buildings over here, and they're deciding largely where the gate is going to be for every person. And so just that distinction is one that affects quality in a profound way. You know, I would much rather put my fate in the hands of a gatekeeper who really was dedicated to health rather than insurance. But we don't do that in this country.
That's certainly true for anything apart from emergency services. Almost anything apart from emergency services, you go through your GP. And it's, you know, that is a barrier as well. But on the other hand, you know, GPs, if you look at some of the evidence, 55% of what they do is reassure people. You know, there's actually an awful lot of, and this must be true in any health system, I would guess, that actually there's a lot of stuff you do want to stop moving on up this chain. But sometimes that can be barriers too. You know, sometimes you do need to get through to a specialist. But that sort of methodology has certainly been very significant for us. There's another difference. We actually have a comprehensive service, except for those things we don't do. Whereas if you're in an insurance-based system, you tend, as I understand it, to have things that are covered. You know, there's much more about specification of what's covered. You know, we tend to say, well, if nobody's told us it's not covered, then it's covered.
Nigel, a question, thinking about reform of the UK system. You ran the NHS, and you've also talked about the difficulty of reform of any system once it's in place, and all of the interests are assembled. If you could redesign the NHS, what would you do? I mean, what are the reforms that you think are now necessary, that are now so difficult to achieve in the United Kingdom because of that legacy inertia you described?
I'm not getting to the second half of the discussion, but the two things I have learned by spending much more time abroad, may I say, that I would do differently in the NHS this time around, was get it right across the hospital community boundary much more clearly, and that's into the non-health providers. You know, this is actually, I mean, because it's the same group of people who spend all the money. It's the same 20%, and they are by and large people with chronic diseases, perhaps towards the end of life, who need care as well as technical help. And we didn't get that boundary right. You know, sometimes we get it right, but not as much as we should do. We get it better than you do, according to all the evidence, but that's a real one. And the other one, frankly, is the shape of our staffing pyramid, if I have another pyramid. I don't know how many doctors and nurses in the room, but here goes. Actually, there's too many people at the top of our system, you know. We overtrain and get people at the top of the system, and we don't have enough people lower down doing more technical tasks, particularly as technology gets better. We are better able to deliver care in different ways, rather than assuming you always need a 9-year trained ophthalmologist to do a cataract and stuff like that. So I'd have been much more radical about that. Where I'd have got to, whether I'd have kept my job for 6 years, I don't know. But you know, I would have been pushing at an expansion of the medical and nursing workforce, but actually an expansion of the other people who do the joining up and do other sorts of professions. And that's where the costs are.
I'm sure we're going to come back to the discussion, especially about medical and nursing personnel in the context of the developing world. But now, as I promised, let me again, please respect that any questions now, let's limit to questions about healthcare reform, comparisons of the system, and then we're going to spend the rest of our time together looking at global health issues, and particularly in the developing world. So questions for either of our panelists? Yes, Michelle. Michelle McMurray runs our healthcare program here at the Institute.
Hi,
Is it on?
It's very interesting to hear about the both imbalanced pyramids, but imbalanced in different ways. And well, Chris, you touched upon the coming wave of medicine, and that's really predictive care. And that sits in an interesting nexus because it's both high technology in terms of For those of you who couldn't hear. It was interesting to hear about the two imbalanced pyramids, both on this side of the Atlantic and on the other, and how one is more technology-based and one is more wellness and population health-based. And yet the coming wave of medicine is really predictive medicine, where you're dealing with using very high technological tests to determine whether people are going to be at risk for disease in the future. And that takes both a high level of technology, but it also takes a very public health and wellness-based approach to make sure people stick with the results of the technology and stay healthy. Which of the two imbalanced pyramids is better prepared for that coming wave of medicine?
Shall I have the first go? I think this is fascinating, and it is an absolute revolution for some of our healthcare, only some of our healthcare. But one of the things that new technology does is it is much more accessible. It doesn't need to come down the old pyramid, you know. And any of us can now go and get our genetic makeup analysed, can't we? And have a direct contact actually with a scientist, not a clinician. So there's an interesting role about where the clinician is and who the clinician is. This is actually disruptive of that whole model. In broad terms, and probably because I'm wearing NHS glasses, I'm more inclined to think that it's better if I'm able to have that dialogue with a generalist at a local level, and who can then signpost me, because I'm going to be confused. I mean, particularly in your marketplace, you know, there are all kinds of people offering me stuff in this predictive area. You know, so maybe I need a signposting person somewhere there, rather than an older pyramid where people are going to have to make some substantial changes in the way they work because of this.
Gentleman in the second row.
Could I
Yeah,
just
please.
take a
Tom
shot at
also
just
wants
quickly?
to
Just
join.
wanted to comment a couple of things. I think technology is going to be a lot more pervasive in health in the future regardless. I think it'll be much more evident all the way through the pyramid. It would seem to me the real question is, do we put greater emphasis on wellness or greater emphasis on illness? And that really, in part, will determine the degree to which we rely on technological applications as we go up. My hope is that we put more emphasis on wellness and the base of the pyramid. But I'd also say that, you know, in sort of the flip to that, the one area where I think technological application could make a huge difference for both wellness and illness is in HIT, health information technology, because we are still largely a paper-driven system in this country, and that, to a large extent, has created inefficiencies and problems with quality that could be addressed with better and more significant, successful application of technology. So you're going to see more pervasive technological applications all the way through the pyramids in the future.
Hello, Leonard Doyle, British journalist. Senator Daschle, could you drill down a little bit more into this issue of ideology? I mean, is it that you think people are taking positions that are against their self-interest? And conversely, in the UK, I mean, we've got a pretty lively Conservative Party, and they believe in the free market. So how would you explain that this prospectively incoming Conservative government embraces the NHS? And am I right in saying it's the biggest employer after the People's Liberation Army?
It's fourth.
Tom first.
I think that the culture of America, the tradition, the political tradition of America largely has been distrustful of government. I mean, there have been exceptions, but by and large that has been the disposition of the American people, especially the farther west one goes, the more apparent that appears to be. And so, and there's also, in addition to that, it's almost become a pejorative term to say, I support another entitlement program. I mean, entitlement in this country is something that is not viewed favorably. It's that individual resilience and that opportunity to be, and do anything you want without government interference. I find it ironic that conservatives at the same time will put severe constraints on and involve government on abortion and a whole array of exceptions that fly in the face of this ideological purity that they have with regard to government's role. But nonetheless, it really starts with that. And the sense that the private sector, the free market, can achieve anything, and most often in a far better way than government can. It isn't unanimous. I would say that's the consensus position in America, and the effort has always been to overcome that, to address some of these things. Slowly, we do, and again, even conservatives, if you think about it, we have a British system in America.
Yeah, conservatives like Medicare, don't they?
Well, they like Medicare. They like the VA. The VA is even the Medicare. You could argue is private-public. It's a hybrid because it's largely run by the private sector, but it's a government program, especially Part D. But the VA is pure government, and it is probably the most wildly popular program among conservatives and liberals having to do with health in the country that I can think of today. The same is true to a certain extent of DOD. DOD has they've now become somewhat of a hybrid in their TRICARE system, but IHS, another one. I mean, so there are government programs that enjoy very deep support among conservatives in this country, but they're the exceptions. And it's still that free market that they point to as sort of the solution across the board, regardless, and we're having to deal with that now.
Nigel, the other part of that question,
Yeah,
conservatives in Britain?
Yeah, two quick points. The first one is, of course, where our system has got to. It used to be a monolithic sort of, your comparisons with the People's Liberation Army. It was as if it was all joined up. Actually, the big change over the last 10 years has been that we've kept the single payer, if you see what I mean, if I try and use American to explain the English concept, as it were. We've kept the single payer, and kept that national framework, national standards and evidence and that kind of stuff. But what we've done is we've opened up the provision. So we've now got a marketplace in provision. So actually, you might be an NHS patient who is actually ending up being treated in a private sector clinic, provided that private sector clinic meets our standards and our costs. Now that's actually a position which I could have imagined the Tory government getting to. But there's another really interesting point here, which is actually about where do you get your ideologies from? And you get your ideologies from the people around you. You also get your ideologies from your own experience. And we're in a very interesting position at the moment, which is that if you look at whether people like the NHS or not, the people who have recently used it, they like it much better than the people who've only heard about it or haven't used it in the last year. And most people don't need healthcare. And it's just exactly your point. So you're always on a loser because you've only ever got 20% of the time in the hospital. If we get them all sick, then actually, the NHS would go up. But the particular focus of that one, the interesting focus of that one, is that both our leaders at the moment have had children looked after in the NHS, and sadly both died, not because of the NHS, may I say, but now they've had personal experience of being looked after, including, obviously, sadly, Mr. and Mrs. Cameron in recent times. That influences leaders and influences people around, that they happen to be part of the 20% as opposed to the 80%. So I think, actually it's a model Tories could buy. I speak as an independent, as you understand. I'm in a wonderful position, an extraordinary position of being an independent member of the House of Lords, but there we go. That I can actually, make my comments my own. And I can see that's a model I can see the Conservatives could buy, but it's actually that gut experience and the communication almost in some ways that goes with that.
Let's pivot. We'll have time for questions at the end to a discussion about global health. And Nigel, I'd like to begin actually with the title of your book. It's a provocative title, Turning the World Upside Down. I didn't really know what you meant until I started reading it, and I think what you're saying is that Western medicine and Western science, for all of its extraordinary successes, and it's the envy of the world, is really not today the answer for many of the challenges in healthcare delivery in the developed world or in the developing world, and that in fact we have a lot to learn from poor countries. Is that a reasonable? But tell us what.
Maybe one quick qualification on that: it is not the answer by itself. I'm not trying to get rid of Western science, but it's not the whole picture, and we've treated it as if it were the whole picture. I got into this, and the very simple story was that Mr. Blair asked me if I would go and look at what more we could do to support health improvement in poorer countries with British expertise and experience. And, great tradition of this, as there is in your country. And I went and did that. And there is a lot. there's a lot more we can do. But actually, I then began to realise how much there was we could learn. You know? There were a lot of things they were doing, and part of it was because they didn't have our money, they didn't have our baggage, they didn't have the legacy kickback. They could actually do things in a different way. And so how do we bring that back? And I've actually packaged this in the book as an unfair exchange. And the relationship between we richer countries and poorer countries, whereby we often take their healthcare staff, and in return we may give them our ideologies and ideas about how you do health, which may or may not be relevant and may or may not have worked in their own country, in our own country. What if we turned it the other way around? What if we actually tried to learn some of their ideas and actually gave them some of our staff? Now that's what the book is pivoted around. So what is it to learn? Let me just take two quick examples. There are some specifics to learn. HIV/AIDS, and seeing Dybul here, very, very nice to see you, and Joan Holloway and others in that field, is some of the things that are done in those areas have been learned elsewhere and brought back to the wider world. Conditional cash transfers in Mexico have gone around the world. In fact, New York City has copied the program, even called it the same as they did in Mexico. There's one where the Americans have
and sometimes also explain what they are. I didn't know what they were. So
right, okay. This is actually a program of whereby you're basically incentivizing the poorest people within a country to get health care. And you do it by, or to get health care or to get other services, and you do it by making any social benefits conditional on, for example, taking your children to school or having antenatal health care or things like that. So you're actually incentivizing people at that lowest level. So there's specifics. There's how you treat clubfoot around the world is now being developed from what happened in Africa. But more importantly than that, there's a general way of thinking about the world. And you go into BRAC in Bangladesh or various places in Africa, and you see the use of communities and families much more. You see the use of social enterprises, which are bodies that use private sector means to public social ends. You see public health and clinical issues much more closely linked. You see people being trained for the job and not just for the profession, and this is one we might come back to because I think this is a really big thing. You see, instead of having all cataracts done by people trained for 9 years, you have some of them done by people who are trained for 3 years on cataract surgery. And on top of all of that, you actually see people recognising that health is part of life, and it's not something completely separate that you deal with over here. And the example of that, again, in somewhere like Bangladesh, is supposing you've got a sick, poor woman in front of you. Part of the issue is getting a health service. But then you think, well, how do you continue to get that health service to her? One mode of thought would be to, well, how do we fund a health service? But actually, the way that BRAC look about it is that empowerment is not just about rights and advocacy. It's about giving people economic independence. Economic issues and health are very closely linked. All kinds of issues are very closely linked together. So they're seeing the world in a different way. So here we've got our wonderful reductionist science, which will actually deal with your predictive, it'll pick you apart in bits you didn't know you have and tell you what you're going to die of, or maybe, hey, who knows, they'll tell you or they'll tell you that. So you've got all of that, and this is fantastic stuff, and God, haven't we done well? We live 8 hours a day longer than our 8 hours a day, we've gained 8 hours a day in the last 30 years. In the last century, sorry. Isn't that extraordinary, in terms of where our life expectancy has taken us? But actually, you need some of the rest of these things as well. And what I argue in the book is that a lot of young people get that. They understand that. They're interested in global health. They're interested in mixing these two different sorts of traditions. And I try and spell that out a bit. And my arguments at the end of the book are in part about how do we promote more exchange? How do we take off our glasses? How do we actually go to a poor country and not just see poor people without our resources, but actually see poor people without our resources, and by God they need resources, but actually see people who are doing some stuff that actually we should be humble about and think about. So that's what's the book about. And when I say this to a number of people, you say it to a number of people who've worked in Africa, they'll say, yeah, actually, when I was there, I thought they were doing this better than we were. And part of the problem is the legacy kickback, as that's the term we're using at the moment, of people, this is how we've always done it, You've got a problem? Get another doctor. Get another specialist. I joke. But, you know,
Or get someone who's not a doctor at all, but who's trained to do the particular thing.
That may well be the answer. Yeah.
Let's actually stay on that a bit, because you talk a great deal in the book about training and education and specialists. You give some wonderful examples, like in Mozambique, about, I've forgotten the term, Portuguese, I presume, about the sort of like midwives, but they're surgically trained to do cesarean sections. What can we do, or what is the proper response to worker migration and the fact that in many African countries, you know, I mean, I heard not too long ago there are more Sierra Leone physicians in Chicago than there are in Sierra Leone.
Yeah.
Talk a little bit about those issues, and I want Tom to talk about them as well, and worker migration issues. What's fair? I mean, we don't want to restrict movement, but on the other hand, there seems to be something fundamentally unfair about our existing patterns of migration.
Yeah, well, I think that's absolutely right. I think it is an unfair trade as things stand. However, it has the two parts, and you're quite right. Why are people moving? It's not just actually because we're sucking them in. You know, can you justify arguing against migration when, you know, where they may be, health workers may be abused in the country that they're in, where, you know, they don't have any opportunities, where they're working in difficult conditions. There are some very big push factors in all of this. And actually part of the migration question is actually the rights of migrants as well. And we shouldn't forget that. Another important point to remember in this is that if every African clinician went home, it would deal with 10% of the problem, just in numbers, if you just do the numbers. So, hey, that's a big and important issue, but the bigger issue is we're not training enough. Or the bigger in numbers issue is that we're not training enough. So part of it is the rights of migrants, but the other part of it is that what are the responsibilities of the UK and the US? I'm very clear about the UK, and I cannot speak for the US, is that we're a global employer. 30% roughly of our health workforce did their first training somewhere else. We have some responsibilities, it seems to me, to be supporting training and education in the countries where people have come from. It's not a sort of transfer fee. It's not a sort of straight compensation that for every worker we get, we send £100 back or whatever. I don't see it like that. I see it as, you know, this is where we are in the world, and we have some responsibility to support our neighbours or our distant neighbours. But the final point is that's not just a matter of morality or whatever, or charity, actually. This is self-interest too. Because you know where the swine flu that will actually get us, or the zoonotic disease that will actually get us, will come from. It'll come from some country with an inadequate health system. And, you know, it'll grow there. And actually, the lack of health workers in faraway countries is actually pretty important to us, because that microbe can be with us in 12 hours, 15 hours, depends where you think you are. You know, that's significant. So we've got responsibilities, but it's not. A lot of this argument about migration is sometimes pretty naive. You know, the fact they've got more Sierra Leone doctors in Chicago if they have, probably means they've got 5. Well, you know, or something. You know, but let's be real about what we mean. Migration is important, but it can distract you from the issue that the countries need to sort something else out for themselves as well. It's not just us foreigners, but actually we should be also supporting.
We do seem to be relying on this country more and more on foreign-trained physicians, foreign-trained nurses. Is that right? And is this a good thing? What should we be doing about it?
Well, I think it is to a certain extent, and I agree with Nigel almost completely on this. I think we have to be concerned about sending the wrong message about immigration and migration and what the Statue of Liberty is all about. But at the same time, you know, we import about 5,000 foreign medical graduates a year. That's 100 medical schools graduating 50 doctors a year, and you know that's sizable. If they were coming from Britain or France, I wouldn't be as concerned. But they are coming from Sierra Leone and South Africa and elsewhere, where those needs are even greater than ours. And I think we have a responsibility to own up to the implications of that, and I think Nigel's response to the problem is exactly the right one. We have to be willing to put more of our resources and commitment into medical education, first here at home, we don't do a good enough job of incenting students to go into good primary care practices. We've seen a 40% decline just in the last 10 years of primary care medical students in this country. And so as that decline...
And why is that? Is that because their compensation is a tiny fraction of what their medical school classmates get in the specialties?
Well, it's crass, Elliot, but I just say follow the money. And students are following the money, and the whole marketplace follows the money. And the money doesn't encourage you or incent you to go into primary care and wellness. And so, you know, to a certain extent, we're relying, as we should be, more on alternative providers, and that isn't, I don't like that term, but on nurses and nurse practitioners, physician's assistants. They're not alternative to anything. They're just good providers. But at the same time, we should be cognizant of the fact that this follow-the-money approach in our healthcare market is drawing people who see it as a real opportunity and creating problems in other countries. And it seems to me we have a responsibility to help those governments deal with the issue. And I don't think we haven't owned up to that responsibility, nor have we come up with any leadership that would allow us, even if we had the resources, to address those resources appropriately. And I think that's key. So I think, to Nigel's point, I call what goes on in the developing world the drip irrigation applications to good health. You know, if you go to the Middle East, especially to Israel, they have drip irrigation systems there that maximize the value of every single drop of water. And that's exactly what developing countries do, it seems to me, with regard to healthcare. You know, we spend 18% of our GDP on health, and we have a $14 trillion economy. They spend 1 to 2% of their GDPs on health. And so what are they going to do? They're going to try to maximize every single scintilla of value out of every one of those dollars they can. And where does it go? Well, Nigeria spends $5 per capita in their country today. And largely that money goes to the epidemics because they have no choice. Malaria and HIV/AIDS. And, you know, if they had more resources, they would do more things. But that's left everybody to demonstrate once again that necessity is the mother of invention. And necessity is driving them to do wonderful things, conserving those resources and coming up with very innovative ways to create better value for that commitment than we have in our own country. So you're absolutely right, I think. I think you can learn a lot on maximum efficiency, and obviously there are cultural and other issues that might get in the way, but nonetheless, there is a lot we can learn. And one of it is just the value of the resources committed and how can we maximize that value in the drip irrigation demonstration of good health.
Cuba is another example of that.
Well, Cuba is the best example of a developing, well, arguably the best example. You know, Cuba has a $4,000 per capita income in their country, but they rank at about where the United States is in overall quality, if you can believe any of the analytical efforts that have been done. On a per capita basis, they have more providers than any developed country in the world today. It's just remarkable, and they get good results. Their life expectancy, the average life expectancy, and I defer to Nigel, but into the developing world is around 50. And but in Cuba, it's 77. They have done with limited resources what we have been unable to do in this country, and it's in large measure because they have put the emphasis on the base of their pyramid, that good primary care and the wellness that they offer, which is virtually unparalleled. No other developed or developing country has the record they have, with the limited commitment in resources and the maximum demonstration of good result.
Can I say two quick things? One is this business of people innovating when they don't have resource. We shouldn't be surprised. And if you look at other industries, you will see this happening to really quite a significant extent. This is happening around the world. Not that we should learn everything, and not that you just apply it, but it will open your eyes to thinking about it differently. But can I just give an advert for the Aspen Institute, which we should have done on the migration issue?
Please.
The Aspen Institute, and Realising Rights in particular, with Mary Robinson and Peggy Clark and colleagues, have done this tremendous job, it seems to me, in developing and supporting the WHO in developing a code of conduct on migration, which has precisely these two parts, which was discussed, I believe, in the WHO, World Health Organization Executive Committee yesterday, and seems to be making progress, so it will probably come up at the WHO Assembly in May, the actual global one, which will actually try and set the framework with rights of migrants, but actually rights of countries to actually have some staff, and some responsibilities for the rest of us. And so, if I may, praise the Aspen Institute and thank our hosts.
Double that for me. I couldn't agree more.
Another question, and then I'll open it up again. One of the themes I think in the book as well, Nigel, is that in the West we tend, when there's a medical problem or a health problem, we start with science, and that's obviously for us how we solve that problem. But you find in many poor countries that the question starts with, well, how do we understand that society? And then we move from that. And I mean, for one of the things that you seem to suggest that one of the most effective things we can do about healthcare, or about the quality of health in many poor countries, is educate more girls. Yeah. It has nothing to do with science or medicine, but it has profound consequences. Can you talk a little bit about that general theme about starting looking at social conditions rather than starting looking at biological conditions? Yeah.
Again, don't let me in any way devalue science. No. This is science plus I'm talking about. But let me give you the British example, and you'll have one. Vaccination. We had a thing called the MMR vaccination in the UK. A particular scientist produced a paper that suggested that it might be a problem. The entire medical establishment over 3 years rose up and said it wasn't a problem. Yet, by the end of 2 years, only 15% of parents in London did not authorise their children to be vaccinated by the MMR vaccine. As a result, measles is now back in London, and measles is killing again in London. Now, that was about public distrust of science and public distrust of authority. And it goes to this point about how culture and science need to go together. Providing the scientific solution is is necessary but not sufficient in that context. In India, came across a village, effectively a Muslim village, where they wouldn't accept vaccination because it was coming from the Hindu authorities. But they assumed it was sterilisation or something nasty anyway. And the sad truth is, of course, that stuff like that has happened. They weren't daft to do it. So there's that sort of issue about how culture and science interrelate. And crucial to that is the other aspect you talk about, which is actually the people who helped us to be healthy more than anybody else is our mothers, I would guess. Whether it's from cleaning our teeth to washing our hands or whatever, if you know what I mean. And actually you see the statistics, as people in this room know better than I notice a number of people who understand this extraordinarily well, that actually it is women who influence what happens in the family much more than anybody else. The statistics show, and I can't remember them instantly offhand, but a girl with 5 years education, her child is 40% more likely to live to the age of 5. It's that sort of extraordinary statistic. And it is about using mosquito bed nets because you believe in them. It is about washing hands. It is about, being able to rehydrate a child with diarrhea or whatever. It's that sort of stuff. Very practical stuff. But actually, I talk to insurers in this country, and I come across them saying, how do we get to mom? Mom? How do you pronounce it? But if you see what I mean. In order to, because they're the people who are going to influence the health-seeking and health maintaining and health improving behaviour of their families. So it's the same story, but you can't. It's two hands. This is science and education and Western scientific medicine, fantastic stuff, and this is real life or society or people or whatever, and we've got to have both. And that's where I think in future we will be thinking about health in a different paradigm, a pompous word, compared to where we've been thinking about it over the last 100 years.
Questions in the front? Oh, we have all three, so we'll go in order here. Sir.
If I may ask the panel to put on its visionary cap for just a moment. Globalization has made employers very sensitive to payroll labor costs. Social Security was designed back in the 30s in a very, very different world. With the presumed demise of a comprehensive health reform bill, what's the long-run future of finance by employers?
I think that it's highly likely. Well, all you have to do is look at what happened in small business. In 1993, 61% of businesses who employed 50 employees or fewer had offered insurance to their employees. Last year it was 38%. So there was a precipitous decline in the availability of insurance offered by small business. That is going to continue. We are going to move farther and farther away from an employer-based system in this country. And somebody is going to have to pick up close that gap. And my guess is, if in 25 years, that we're likely to see more of a government role just because that vacuum has been created and it needs to be filled.
Yes, please. Actually, why don't we take 2 questions now, and then we'll do 2 or 3 at a time, so each of our guests can answer.
Yeah, Alex Prick at the World Bank. Almost every developing countries look at UK and US as a role model. And I would say in the last 20 years, the UK has been the positive role model and the US has been the negative role model. So every country has emulated the national health system, and they have it as a Ministry of Health. I mean, Ministry of Health in most developing countries is essentially a national health service. And because of that, they've had lots of problems because the National Health Service in the UK has lots of problems in terms of funding and et cetera, et cetera. And so every Ministry of Health has problems trying to figure out how to balance the budget, how to manage staff, et cetera, et cetera. And every country looks at the US and says, we don't want that system because it's fragmented, they have lots of problems, et cetera, up until about a year ago. And then a year ago, with all the problems in the UK health systems, which they all have, suddenly the US is going to reform its system. It's going to introduce insurance. It's going to give insurance to the disempowered, the people who are out. And suddenly the US, Obama goes to Ghana. Every kid in Africa wants to become president of the United States. And you hear the reforms in the US. And then suddenly they wake up on Tuesday and hear of some senator in Massachusetts, and their dream has suddenly evaporated. And I've had at least 100 emails since then where people are saying, we don't understand. What in the world is this all about? Now, maybe if I could ask the panel, what is this all about?
And let's take that. That's an easy answer. One more question, and then we'll hear from both panelists, and then we'll take 3 more.
Well, Nigel, congratulations on your book, because I think you have it exactly right. There is an enormous amount we can learn, whether it's medical record systems. Some of the most innovative electronic medical record systems are coming out of Africa. How to utilize healthcare workers, extraordinary. But I'm not sure it's just necessity, because we have the same necessity in Alabama, and we haven't done it. In fact, Mike Sag brought what he's doing in Zambia on AIDS through PEPFAR to Zambia and started a new program there. So we have the same necessity, but we don't seem to be doing it.
Yeah.
And some of it, too, you talked a lot about cultural for the U.S., but the culture of development, our terms aid, assistance, donors, pretty much dictates this paternalism of what could we possibly learn from them. We are the white knights literally coming in to save them. So how do we change this mentality, this culture? President Obama in Ghana talked about partnership, not patronage, which is a great echo of President Bush, who always said partnership, not paternalism. But then you get to the ground, and the paternalism is very much there. And the U.S. is no different than Europe on this. And to be honest on this, I think Europe even might have a little bit more than we do. So how do we change that culture? And then with a caution there that we not go too far and go back to the 1800s noble savage, which I'm afraid actually we're tilting back towards, and saying everything they're doing is so wonderful. And, the Nigeria is a great example. The inefficiency there is mind-boggling, makes us look like amateurs, and the accountability structure. So how do we really develop a true partnership of respect in a way that we learn from each other, which means changing culture?
Either gentleman to comment on either of those.
Let me comment on the second one, because it's partly in my mind, and I absolutely agree. And I'm in danger of sounding like I'm supporting the noble savage argument if I'm not careful, Mark, and thank you for giving me the opportunity to say that you know better than I do that actually there are wonderful examples and there's awfulness. And I do say this in the book. Do not think that everywhere one goes, there are, as you say, we're amateurs at some things, aren't we, in terms of where we're coming from. But to get to the point about aid and development, I agree with you. Language is fantastically important. We go back to the health bit of it, like alternative practitioners. So what's, as Tom said, what's alternative? Task shifting, Why are you looking at it through the world of professions? Why don't you think about the job that needs doing? And aid and development are terribly trapped for this reason. I talk about co-development, and I talk about mutuality and respect. And respect and mutuality means that I understand the bad things as well as the good things. This isn't a mutual I nearly said mutual backstabbing. I mean mutual back scratching, isn't it? Exercise. This is looking at life as it really is. And I think there are two things here. Firstly, I do think younger people get this much more than people of my generation. And it's partly because, you've war-gamed against each other or whatever. People are much more joined up and don't have some of the boundaries that I think people of my generation have grown up with. That's why my argument in the book is that the most important thing we can do to help make change here is to expose people to other people and to actually get more Brits and Americans supporting African development by actually doing stuff under the leadership of Africans. And I'm concentrating on Africa and saying what I'm saying, but the same applies elsewhere. Much more exchange, much more opening of our eyes, much more recognising that some of the stuff you may have learned at nursing school or medical school actually was just about how you do stuff in organisational terms. It wasn't about medicine or nursing. And I think that's where the mutual respect will come from. I think people, when they're put together, a lot of them do generate mutual respect, and it shouldn't be modified by organisations. It's about face-to-face, and that's why I make this strong recommendation in the book that we should be getting more people engaged in this sort of process, and why I actually have two colleagues here, if I may just point them out. David Percy, who's actually a British GP, if David, you'd just wave your hand, and Susanna Ejang further back. And we're talking about how do we actually operationalise a more systematic way of getting more people engaged across the continents.
Tom, any?
I think we have to bring about it. I'll try to take a quick shot at both. I think we have to. There are two transformations that have to occur. One is this notion of these countries being dependent to our notion in the future of our interdependence. And I think that interdependence distinction is really important. The other is the notion that they're irrelevant to the fact that they are becoming increasingly relevant. So it's their relevance that is brought about by a recognition of our interdependence that would create, I think, perhaps a new mindset that over time with leadership we could achieve. But it seems to me we've had almost a condescending view of the developing world as irrelevant and dependent. And I think those two concepts have to be transformed to interdependent and relevant before we can hope to achieve anything. With regard to the first question, I think that we have to come to a really tough question in this country about governance, and that is, do we want to require, for all intents and purposes, on every issue that passes through Congress now, a supermajority? That's never happened. At the turn of the 19th century, the 20th century, we had 3 filibusters at Congress, and that was a lot, but that was roughly what we had. Now we have over 100 per Congress, and for all intents and purposes, you need 60 votes now to pass anything, and we have in essence now a parliamentary system requiring a supermajority, and there is no way you're ever going to deal with the most contentious issues in this country, whether it's climate or foreign policy or health care or any one of a number of other issues, nuclear proliferation, requiring a supermajority, even on procedural votes. It is going to relegate us increasingly dysfunctional. And when that happens, we become less relevant, if I can use the word in another context.
Other questions, and we have just about 6 minutes, so we'll take 2 or 3 questions, and we'll see if our panelists can answer them quickly. Yeah. Here, and the woman in the back.
Elliot Sorrell, George Washington University. Nigel, congratulations on your book.
Thank you.
And Senator Daschle, thank you very much for your insightful comments. Just two questions. First, a statement. I think culture, science, and incentives are relevant to both the developing world and developed world. And the issue of health behavior is relevant to both. Health behavior is probably the single most prominent modifier in outcomes. It's relevant across the globe. Two questions. Senator Daschle, how do we get our great country, our wealthy country, to move from a health market to a health system? And to you, Nigel, I appreciate the WHO and the WHO Assembly, but it is more of a show and tell than action. Forgive me for the hyperbole. How do we get to develop a global governance system that will take into account the mutuality and the mutual benefit to integrate science, culture, and incentives in a health behavior that will enhance outcomes across the globe? Thank you.
Thank you. And this gentleman?
It's Hugh Mullen, George Washington University. Congratulations, Nigel. A great book and really terrific galvanizing ideas. I wanted to ask a question that I think pertains to both countries on this issue of our posture towards importing workers or enticing workers. In both countries, both in medicine and nursing, and I suspect in pharmacy, though we don't track it very well, we've created a magnet or a vacuum, really, by not training as many physicians or nurses as we need. And this is a place where domestic policy and foreign policy come together. In the United States, in particular, we put enormous amounts of money into graduate medical education, that is the training of residents. And it is that workforce, the residents, that become our permanent doctors. And as the Senator pointed out, we have had large numbers, 5,000, 6,000, 7,000 a year, that come in because we don't train as many graduates of medical schools as we do residency programs. So at this point, there's a general concern, a general consensus, we may need more doctors in the future. And there have been strong forces pushing for further federal investments in graduate medical education. And if we did that, the only place to get doctors is abroad. We would increase the pull on other nations. So even as PEPFAR and others step up to get involved in this, we have domestic forces that are saying, put more money, and that means we'll increase the brain drain. In the UK, you increased your medical schools some years ago, and in an effort to be more self-sufficient, and I think there was probably a political background to that, which I don't know. My question is, how do you link this global concern of, put it in the domain of foreign policy, if you will, with domestic concerns that really don't focus on these issues? And when the issue of Medicare graduate medical education money comes up, billions of dollars, it's hard to get the medical community to say, wait a minute, this is going to take us in the wrong direction. How do you link the global with the domestic?
And in the back. And then if you could be quick, and then our panelists will try to comment as best they can, but the questions themselves are provocative and interesting.
So I wanted to ask what we're going to do about medicines. Oh, US journalist, by the way, Francis Sellers. I wanted to ask what we're going to do about medicine's success, and by that I mean its technological success. A colleague of mine wrote a wonderful piece documenting the treatment of heart attack for the past 40 years, and if you go back 40 years, I think there was about a 6% success rate, aspirin and a whiff of oxygen and a prayer maybe when you went into hospital. The success rate's gone up enormously, so have costs. People have stents, now drug-eluting stents, and get home with a basket full of medicines they'll take for the rest of their life. That, it seems to me, has the potential to bankrupt individuals here, the US system, the British system, and probably Africa and India when these technologies spread. And I'd love to hear your thoughts on that.
We have three questions that are going to be answered in 30 seconds, but they're all related in an interesting way, and I think we'll use the last time we have to have each of our panelists, if they can, comment on those questions, but make some kind of concluding remark.
Let me take that first one. I won't ask people in the room to say how many people are taking statins, but good part. UK, it's £2 billion, I understand, but actually it's probably saving us money as well, because what happened to people, heart attacks, actually people died, and that was relatively cheap, I guess. But that didn't always happen like that. And the alternatives are expensive. The trouble is when you see something like a statin as an add-on to a system, rather than recognizing that it's got to change the system, you've got to take something else out, because actually those patients we're going to need some treatment otherwise. I think these two big issues down here, I really don't think I can do anything other than say the terribly simple point that's sometimes sort of forgotten is that we do need the global frameworks, and we do need the legislative stuff, and we do need health reform happening from the top. But unless it happens from the bottom, it won't happen. You need both elements of this, as it were. And that's why I continuously think that the biggest group of people who need to be influenced around this debate is actually health workers. And that they will be influenced through their own experiences and how they're trained and how they're developed. And then they influence us. Terribly simple, potted answer to a complex set of questions. But until we start to change the way the professions, or actually, can I step back? My book's about what people are telling me they're doing. People are changing. People are moving. And I'm trying to pick out what the pioneers are doing and explain and to sort of bring it up into light, because actually this stuff is happening. But it's those people who will change reality. But you need the top level stuff as well.
Senator.
Well, those are three such thoughtful questions, and it really would not do them justice to try to answer them in 30 seconds. But I'll just quickly, I think one thing we have to continue to put greater emphasis on, especially in the United States, is the acquisition of best practices and approaches to evidence-based medicine and comparative research that would allow us a better judgment as to when to use these medicines and when not. We don't do that today because, again, we're in a market, and in the marketplace, we're incented to use these things because it brings about the profit that drives the market in the first place. So I would put greater emphasis in this country in acquiring an across-the-board acceptance of best practices and utilization. Secondly, with regard to incenting medical providers, I think we have to do a better job of targeting the resources and putting a greater emphasis on where we want those resources to be spent. I don't think we do a good enough job of that today. And as a result, I wouldn't call it abuse, but there is a significant degree of generality applied to medical education that could benefit from greater focus and far more successful prioritization. With regard to the market, I think ultimately, again, necessity will drive it. I can't imagine we can sustain the current trend we're on. And unless we come to the realization that we need to create a system in this country, we will never get there. Churchill was famous for a lot of observations, and his one that always stands out when I think about healthcare and Winston Churchill is that Americans will do the right thing after they've exhausted every other possibility. and to a large extent, we've virtually exhausted every other possibility.
Well, ladies and gentlemen, I'd like to thank, on behalf of the Institute, these two wonderful panelists. Thank you. And I remind you that we have their books outside, which they'd be very happy to sign. Thank you again.
Thank you, Elliot.